So we're going to be speaking about the neuropsychopharmacology of psychedelic drugs. But before I do so, I want to just acknowledge and disclose that I'm a scientific advisor for two companies in the psychedelic space, WavePaths and Mindstate Designs. I also have received grant funding from an industry sponsor in the space, and I've received consulting fees from Atai Life Sciences. Nothing that I'm going to be talking about today is actually directly related to any of those disclosures, but we, of course, are better safe than sorry. And I hope by the end of this lecture, we will be able to summarize current knowledge regarding the acute and enduring effects of classic psychedelic drugs, that we will be able to evaluate preliminary evidence for therapeutic efficacy of classic psychedelic drugs in patients experiencing mood and substance use disorders, and to hopefully discuss future directions for psychedelic research in psychiatry. But let's start at the beginning. What are psychedelic drugs? Well, if you look in the dictionary, you're likely to find definitions that include phrases or words such as sensory perception or perceptual distortion or hallucination, or even words describing very big feelings. And while these may be true, many times they're not true all of the time. And I would argue that these descriptions point to some of the less or least interesting aspects of psychedelic experiences. The word psychedelic itself is derived from the roots psyche, meaning mind, and delos, meaning manifest. This phrase was coined by Humphrey Osmond, who is a British psychiatrist expatriated to Canada, who among colleagues such as Abraham Hoffer was the first to give LSD to patients in a clinical setting. He had established a clinic for alcohol use disorder, or alcoholism as they called it at the time, and that was in Saskatchewan, and Humphrey Osmond claimed to have treated thousands of individuals over a 10 to 20 year period, and also claimed remarkable effects, which we're going to touch upon a little later. But Osmond himself had tried LSD as well as psilocybin and mescaline, which are all compounds within this classic psychedelic space. And he gave psychedelics to his friends, and he famously gave mescaline to Aldous Huxley, who was a novelist and philosopher who penned The Doors of Perception, based on his experience with mescaline that Osmond had given him. Osmond tried LSD. He used LSD to try to better understand its effects and its properties, and to try to better understand how LSD might be useful in the clinic. And he really was convinced that LSD specifically was able to manifest or reveal or uncover some aspect of consciousness or the mind that the individual may not have had access to before that experience, or may not have been aware of. And it was really these kind of mind manifesting properties of LSD that Humphrey Osmond thought were of the most critical to therapeutic effects. That's just a definitional overview very quickly. On a more practical level, what drugs fall into a psychedelic class? Well, if you take the broadest definition or the broadest interpretation of that phrase psychedelic, meaning mind manifesting, I would argue that my cup of coffee this morning was somewhat mind manifesting, but I don't think that that's what Humphrey Osmond meant. People these days are calling a number of different compounds, such as psilocybin, which is the active component in hundreds of species of mushrooms, mescaline, which is a psychoactive component within certain species of cacti, and research chemicals that don't occur naturally, such as LSD. These are what we think of as classic psychedelics, but people are also calling ketamine and dextromethorphan psychedelics. They're calling more exotic compounds such as salvinorin A and ibogaine. Those are being called psychedelic. MDMA is being called psychedelic, and some people are even calling cannabinoids psychedelic. But these are all drugs in very different pharmacological classes with very different and differing molecular mechanisms of action, different abuse liability profiles, different subjective effect profiles, and arguably, if they are any of them therapeutic, they're very likely to have different therapeutic models built up around them. I'm not going to be talking about all of these compounds today. I'm really going to be focusing in on the classic psychedelic drugs, which themselves fall into multiple pharmacological categories. These include tryptamines, which are most similar to serotonin in chemical structure, including psilocybin, which is, again, the psychoactive compound in dimethyltryptamine, which has very many plant sources. There means there are just a couple of compounds within psychedelic drug class, including LSD, that do have direct D1, D2 receptor affinity, but those are few and far between. What I'm going to focus in on today most is really psilocybin. Out of all of these compounds, we're going to talk about psilocybin primarily because this is the compound that has the greatest amount of evidence behind it for any therapeutic indication in the modern era. And psilocybin specifically is currently in phase 2B and phase 3 registration trials for the treatment of major depressive disorder or treatment-resistant depression, and both of these multinational registration trials have received breakthrough therapy designation from the FDA. I want to be upfront about discussing risks of psychedelic drug administration. We believe these risks generalize more or less to all classic psychedelics, but they are most well known for psilocybin. Psilocybin is known to evoke a modest but somewhat reliable increase in heart rate as well as blood pressure. On the right, we see a table derived from and summarized from a few different clinical trials in which we've administered ascending doses of psilocybin to healthy individuals, and we see mean systolic and diastolic blood pressure rate rising as a function of dose. And again, these are averages. They don't describe the outliers. The outliers of systolic and diastolic blood pressure can get into certainly far above simple hypertension. Very rarely do blood pressures get above 170 over 90. But we do have ways of trying to mitigate that risk. Aside from heart rate and blood pressure increases, acute effects of psychedelics include a number of physiological effects, including dizziness, weakness, sometimes paresthesia, drowsiness, blurred vision, tremors, nausea. These are all risks that are dose dependent and time limited. The greater the dose, the greater the chance of these adverse effects. And these adverse effects are nearly all limited to the time course of drug action, which lasts about 4 to 6 hours for psilocybin. There are a few compounds within the classic psychedelic umbrella that may present a risk for serotonin syndrome. LSD is one of them. Another psychedelic mixture that is administered in at least kind of indigenous and early clinical trial contexts is ayahuasca. Ayahuasca is a plant admixture, including the psychoactive component dimethyltryptamine, as well as compounds such as harmine, harmaline, and other compounds that may act as monoamine oxidase inhibitors. Of course, we want to be very careful when administering monoamine oxidase inhibitors to individuals who are taking drugs or also food that may increase serotonin levels. But this serotonin syndrome risk is not really known or documented with psilocybin. Those really describe the sum of the physiological risks that are known for psilocybin. More prominent among risks of psilocybin are psychological risks. Acutely, psilocybin and other psychedelic drugs can lead to some potentially psychologically distressing experiences, including paranoia, fear, sensory disturbances, grief, trouble with reality testing. People describe the feeling that they are going insane, or other very strong and incredibly potent and potently described states of consciousness. These can be mitigated quite readily within carefully controlled circumstances, which we're going to get into in just a moment. But also, I'd be remiss without acknowledging risks in uncontrolled settings. People who are self-administering psychedelic compounds can certainly enter into situations where they are harm to themselves or others. Their psychiatric distress may lead them to poor decisions. They may have a kind of lack or breakdown of cognitive control or cognitive processing that could lead to psychiatric emergencies in some cases. With all of these risks come potential for mitigation. So the current best practices for research administration, which would translate well into clinical administration for psychedelic drugs, are all built around mitigating these risks that I've described. At first, we want to essentially really carefully medically screen patients to make sure that they don't have some lingering cardiovascular risk or susceptibility to risk that may be exacerbated by an increase in heart rate or blood pressure. We exclude those who are taking contraindicated medications, and with psilocybin, many of these contraindicated medications include any essentially serotonergically acting drug, not necessarily for psilocybin because we feel that this is necessarily a medical risk, but due to the possibility that these compounds may blunt the effects of psilocybin, but also because this kind of risk space has not been fully mapped. We also carefully exclude those who are at risk for psychosis. This is for a number of reasons. Early in the medical application and clinical study of LSD, psilocybin, mescaline, and other compounds, individuals, including those such as Humphrey Osmond, who themselves had some experience with these compounds, and others who did not, but who had observed the effects of these compounds on unwitting or unsuspecting patients or study participants, really saw a lot of signal that spoke to the potential for psychosis in these compounds. In fact, they were labeled as psychotomimetic or psychosis mimicking compounds at early phases of research. There are a lot of reasons that we may question that any kind of direct attribution of psychedelic experiences to psychosis. If I understand fixed, frank, and idiosyncratic characterization of these is not always going to hold. Many experiences people have during a psychedelic experience are not necessarily fixed, and importantly, they're really amenable to insight. You can readily describe or remind a person that they've taken psilocybin or a psychedelic drug, and that that you're here with them to help them, and that it's going to be over soon, and people respond to that quite well. But also, there is the beginnings of evidence that these compounds may uncover or otherwise precipitate the onset of psychosis in people who have a vulnerability to that. In 1960, a psychiatrist named Sidney Cohen at UCLA had published the results of a survey that he had conducted with all of the individuals in the US, at least, that he knew were administering LSD in clinics or research labs. Among the questions on the survey that he circulated were, how many people have you administered LSD to? How many doses? What were those doses? And have any of your patients or participants had a psychiatrically concerning reaction that lasted more than 72 hours? And caveats abound. Less than half of the individuals to whom he sent this survey responded, so we don't know what the other half of the survey responses would have said. Of those responses, I don't believe anybody followed their patients for longer than a week after any given particular LSD administration, and so we don't know if there were longer term experiences that were precipitated by any particular LSD administration. But from these responses, the responses characterized over 25,000 LSD administrations to over 5,000 individuals, which is a substantial amount of data. And of these reports, a sum total of 3 individuals were reported as having a lasting psychiatric reaction. One of those individuals was someone who had been hospitalized for schizophrenia and was being administered many high doses of LSD. The second individual had an identical twin who had schizophrenia, and the third individual had a non-identical sibling who had schizophrenia. And I think we know enough about the heritability of schizophrenia and other psychosis-related disorders that we can begin to connect the dots. There have been a couple of follow-up studies that have shown, and surveys that have shown, a similar incredibly low but non-zero incidence of this potentially happening. And there also seems to be a distinct concern that administering a powerful serotonergic compound such as psilocybin or a related compound to folks who are suffering from bipolar disorder with mania, that this may itself precipitate mania. So that's all to say that we go to great lengths to try to exclude those folks who have a personal or family history of psychosis from entering our studies. After that very careful screening, we undergo a minimum of 6 to 8 hours of preparation sessions. These include unstructured counseling for patients, and a lot of rapport building. Really, the purpose of these, aside from trying to explain to a participant what may happen during the experience, is to really put them in a place where they trust us and we trust them, and that we have an open relationship, such that anything that comes up during the drug experience can be discussed and can be addressed. After screening and preparation, we undergo an all-day experimental drug administration session. Participants come in the morning, they complete a final few screening tasks. We would administer a capsule containing a compound in the morning, maybe roughly 9 or 10 a.m. And we then have 2 staff members who will monitor the participant for at least 6 hours, which is the typical time course of drug effects of psilocybin. And they are simply holding non-directive, non-judgmental presence. There's no structured psychotherapy going on during this time. If we can help it, there's no psychotherapy going on at this time. Participants are asked to lie on a comfortable couch in a calm, comfortable living room-like setting. They wear eye shades and don headphones, playing a pre-selected playlist full of mostly Western art music. They're tucked into a warm blanket and given the instruction to turn inward and be present for whatever arises in consciousness. And during this time, participants are encouraged to maintain an inward focus. If they say that they're having trouble, or they're scared, or they're frightened, or they're experiencing grief, the typical response would be to essentially hold that individual's hand and give them reassurance. And in nearly all situations, this has been, we have been successful in helping people navigate these experiences through reassurance. At the end of the day, we will debrief with participants. Once the drug effects have subsided, we will hand them off into the hands of a loved one or a friend who will take care of them and take responsibility for them going home, being safe. And we ask participants before they return the next day to write down everything that happened. It can be as few as 2 bullet points. It can be as long as you can tolerate. But the next day, we ask people to return to the lab, and we review that their own description of what happened with them. We enter into a discussion. We fill in the blanks. We reflect what our experience was as guides or facilitators in the room. And this begins a process of really kind of reflecting on the experience and trying our best to understand how to integrate that experience within a person's life and to help them move on. We invite and encourage people to return to this description and treat it as a living document, which they can then kind of work with for days, weeks, months, and even years after the experience. Often returning to this description of the experience can be a touchstone with which people begin to remember more of the experience or continue to have insights related to that experience. So that's the package. That's what we mean when we say psilocybin-assisted therapy or psychedelic-assisted therapy. I want to now go through a few different levels of what these drugs do, acutely, post-acutely, and then possibly on a more mechanistic level. So let's discuss, well, what do psychedelic drugs do acutely? When people hear the word psychedelic or hallucinogen, you may think of sensory disturbance, elementary hallucinations, kaleidoscopic or geometric visuals overlaid upon the visual field, or something a little more subtle, maybe edges becoming more salient, or the hue of color being more rich or vibrant, or things of this nature. Again, I would argue that these are the least interesting of the acute effects of psychedelics. Somewhat recently, we've described a number of dissociable effects of psychedelic drugs on a variety of dimensions of cognition. One of those is executive function. So in a dose effect study comparing multiple doses of psilocybin to placebo, as well as a high dose of dextromethorphan, which is an NMDA antagonist drug found in cough syrup. People will often misuse this compound as it can have psychedelic-like effects anecdotally. and subjectively. During the effects of multiple doses from 10 to 30 milligrams of psilocybin being a very high dose of psilocybin and a very psychoactive dose of psilocybin. During these experiences, we had people complete the digit symbol substitution task. In this task, you have an array of figures across the top of the screen under which are numbers for each figure, and then you're presented a figure one at a time in the center of the screen, and your task is to press the number on the keyboard that is matched with the figure in the array at the top of the screen. Outcome measures for this task include the number of trials attempted within 90 seconds, the accuracy of those trials, as well as the response time. Well, the response time is really a function of the number attempted. And those are the two main outcome measures of this study, of this task. And in each of these graphs, we see white bars, which are pre-drug administration baseline measurements, as well as administration measurements 2 hours after capsule administration, which is really at the peak effect, the peak of subjective effects of the drug. And what we see is a dose-dependent decrease in the number of trials attempted under psilocybin, with the highest dose of psilocybin equating to a reduction in number attempted similar to that high dose of dextromethorphan that we administered. But what we don't see is a decrement in accuracy with increasing doses of psilocybin. This is really kind of striking to me. It suggests a classic speed accuracy trade-off in cognition, which is actually interesting on multiple levels. The first is on a metacognitive level. People may have the awareness that, wait, I have to slow down to maintain my accuracy, and I still want to do a good job on this task. That's one thing. So that metacognitive component is still intact, even under a high dose of psilocybin. And also, this cognitive process, the cognitive processes that are required to complete this task, are also intact under a high dose, even a high dose of psilocybin, whereas they are not intact under a high dose of dextromethorphan. Another effect that we do see here as well is, I call it substitution recall. So after 90 seconds, the array at the top of the screen goes away, and you're presented with one figure at a time in the center of the screen, and you have to remember, well, which number was that paired with? And we see a dose-dependent decrement of substitution recall or associative learning during the effects of psilocybin. So even within the same task, we're seeing a dissociation, a double dissociation of effects, whereas effects, cognitive processes are intact for the completion of this task, but associative learning during the task is impaired. We also see an interesting, somewhat dissociation of effects between psilocybin and dextromethorphan in a classic working memory task called the letter MBAC task. This task has 3 levels of performance. In the 0-back task, you have to press a button whenever you see the letter X. In the 1-back task, you have to press a button whenever you see the letter that came from the letter. It's the same as the letter before it. So in this task, you see one letter on the screen at a time. And for each letter that you see, you have to make a response or no response. And in the 1-back task, you see an R, then an H, then a C, then a K, then an R, then an R, and you press because that R is the same as the R before it. In the 2-back condition, you press the button whenever the letter on the screen is the same as the letter that was presented 2 letters back. And even for a cognitively intact, healthy adult human being, this is 2-back task is a bit challenging. And we see now the white bars represent performance in the 0-back condition, and the gray bars represent performance in the 2-back condition. We see that the 0-back condition is intact across levels of psilocybin, which is really almost like a go no go or a response inhibition task. And then the 2-back task, we see a decrement in discriminability of trials, which is related to performance. We see a decrement in response bias, and also an increase in the response time for correct responses, dose dependently for psilocybin, but no appreciable effect for dextromethorphan. And finally, this is a complicated slide. Let me give you the gist. In a task indexing episodic memory, or memory for a list of words, we administer an encoding phase during the peak effects of psilocybin or dextromethorphan, and this consists of one word at a time on the screen, and you're supposed to just memorize these words as they're coming by. And then 6 hours later, after the drug effects have worn off, we ask people first, in a free recall sense, can you just tell me all the words you remember? And then we challenge them with a list of words, some of which that have been presented before and some of which haven't. And in terms of the recognition, this receiver operator characteristic curve has a less area under the curve when you're less accurate at recalling or recognizing words that were shown to you before. And the take home here is there are no effect of psilocybin on episodic memory performance, but there is an effect of dextromethorphan on memory performance. So far we've covered very briefly perception and some dissociable effects of psilocybin on various cognitive processes. Some really important and maybe the most peculiar and most fascinating of subjective effects and acute effects of psychedelic drugs are maybe most generally described as peak experiences. These are experiences for which the field has struggled to come up with really adequate language and good operationalizations. Some have called these experiences ego disillusion. We have really more thoroughly used a model called mystical experiences to describe what people can encounter during high doses of psilocybin. The concept of a mystical experience harkens back at least to the work of William James, first described in his Varieties of Religious Experience in the early 1900s, then picked up and further developed by Walter Stace in 1960 with a book on mystical experiences. Stace was a philosopher of religion and a philosopher of psychology, and he went through all of the texts that he could find in the world, all of the recorded texts that described something that seemed like a mystical experience, did a dense and expansive qualitative analysis of those descriptions, and came up with a model in which a mystical experience consisted of a feeling of unity or oneness with yourself, oneness with the world around you, oneness with the universe. Really, this unity is best characterized as a breakdown of boundary between self and other. Also, other descriptive aspects of the experience, such as a feeling of sacredness, a feeling of noetic quality, or there was something like at a ground level purely true about the experience, a deeply felt positive mood, transcendence of time and space, such that the experience of time and space really began to disintegrate or broke down completely, and ineffability, or the inability to really describe these things in words. When we try to quantify mystical experiences during and after psychedelic administration sessions, we don't ask people, did you have a mystical experience? Rather, we give them a questionnaire, and what kind of psychologist would I be if I didn't have a questionnaire? We give people a questionnaire in which they rate each of these dimensions of experience. To what degree did you feel at one with the world around you? To what degree did you feel joy or ecstatic experiences? Rate on a scale from 1 to 5 how much the experience of time seemed to dissipate, or things like this. And from this, we can quantify to some degree a self-reported mystical experience. So these are all kind of subjective or cognitive level behavioral descriptions and models and kind of domains of experience that we have studied. There are also a number of circuit level models in the brain that have been proposed to try to explain how and why some of these things are happening. I'm not going to go into depth with any of these. We could spend an entire hour talking about one of these. But briefly, there's the corticostriatal-thalamocortical circuit model. This is a model that's been implicated in various aspects of psychosis, and has also now been really kind of well studied to some degree to try to explain the acute effects of psychedelic drugs. In this model, the thalamus is a bit of a kind of sensory gate. And the thalamus is a structure responsible for kind of passing sensory information onto the cortex for processing. The cortex provides some kind of top-down input or top-down feedback to the thalamus and the striatum in order to modulate and moderate the sensory information coming forward. And there are really bidirectional connections between the cortex and the thalamus to manage the passage of sensory information. With the onset of a psychedelic experience, but really with the administration of a psychedelic drug, there are 2A receptor sites along this entire corticostriato-thalamocortical circuit. And it's not exactly clear where this begins, but the model describes an effect by which psychedelic drug administration and really serotonin 2A receptor signaling begins to disrupt this circuit, maybe first disrupting thalamic gating to the cortex, such that a greater flow of sensory information goes from thalamus to cortex. That greater kind of influx in cortical sensory information begins to reduce the ability of the cortex to provide top-down filtering information, which then turns into a positive feedback loop. The cortex becomes overwhelmed with sensory information, and then everything else happens. This may be a good model to describe sensory disturbances as well as breakdown of cognitive control during psychedelic experiences. It may not describe everything with psychedelic experiences. Another model that we're working on is the claustrocortical model, where the claustrum, which is a deeply kind of seated thin strip of cortex in the center of each of the hemispheres, the claustrum, we believe, may be responsible for the instantiation of cortical networks in response to task demands in the environment. And really, the claustrum itself may act as a bit of a meeting planner or a switchboard or something of this nature to help really shift network states to respond to changing demands, both internally and externally. The claustrum is also one of the brain regions that most densely expresses serotonin 2A receptors. And it is of great interest to us for that reason, but also because I believe in Francis Crick of DNA fame. His last publication, it may have been published posthumously, he and Christoph Koch, who's a famous neuroscientist, proposed that the claustrum may be the conductor of consciousness. The claustrum is one of the most densely interconnected regions to all areas of cortex. And if there were one brain region that were responsible for seamlessly stitching together our continuous percept of the world and conscious experience, seamlessly stitching together all of our sensory perceptions, thought processes, and actions, then the claustrum would be perfectly situated to do so, given its interconnection to just about everything. And it turns out the claustrum is not tonically active in awake and behaving animals, which you would expect if it was stitching everything together, but it may actually be the conductor in a separate sense, in which it directs transitions between different brain states as we are continuing to go about the world doing human things. And with washing on psychedelic drug or increasing serotonin 2A receptor signaling in the claustrum, we believe that reduces claustrum activity and connectivity to the cortex, taking away that kind of manager of managing switching between network states. And we believe that may be another explanation of why people experience such vastly different states of consciousness. And the hippocampal cortical circuit model makes a somewhat similar claim insofar as if models of the world and predictions of the world are being instantiated in cortex, and the hippocampus is involved in memory processing and kind of the interplay between these regions is involved in responding to predictions about the world, psychedelics may break down that model. But this I would call a theory rather than a model. It hasn't been too well described yet, and it requires a lot of fleshing out. So in summary, what do psychedelics do acutely? Well, they lead to changes in perception. They lead to selective impairment of certain cognitive processes. They lead to high doses of psychedelic drugs can lead to intense subjective experiences or peak experiences that may have varying, and all of these things may have varying circuit level models that could explain them in terms of neural circuitry. Now I want to briefly bring you through what psychedelics do post-acutely. And I think this is one of the reasons that people are so excited. It seems that under controlled conditions in properly screened individuals, classic psychedelic drugs may have rapid and durable therapeutic effects across a number of indications. So far, the evidence is beginning to amass behind cancer-related anxiety and stress, which may also be adjustment disorder. We have major depressive disorder and treatment-resistant depression. We also have studies now that have been published on tobacco use disorder, alcohol use disorder, and studies ongoing with cocaine use disorder, opioid use disorder, cannabis use disorder, and the list is growing. The first clinical finding out of our lab at Hopkins was published in 2016. This was one of the largest clinical trials at the time to study the effects of psilocybin in a clinical population. And the question was whether we could use psilocybin to help reduce depression and anxiety secondary to a late stage cancer diagnosis. And if you've ever known someone who has had cancer or late stage cancer diagnosis, or yourself have encountered one, you may know that this existential crisis may be one of the most difficult things to treat aside from the actual cancer. And in this study, 50 patients were randomized to receive either a high dose of psilocybin in their first session or an incredibly low trivial dose of psilocybin, a non-psychoactive dose of psilocybin in their first therapeutic session. After a couple weeks, participants were crossed over to receive the condition they hadn't received. On the left, you see two plots. One is the GRID-HAM-D for depression, the Hamilton Depression Rating Scale, and the Hamilton Anxiety Rating Scale. And on the y-axis, you see severity of depression or anxiety, and on the x-axis, you see time. So from baseline to right after the first treatment, in red, we see the effect of psilocybin on the individuals who received a very high dose of psilocybin first. A precipitous drop into both depression and anxiety into remitted stages that persisted to at least 6 months. Very interestingly, the blue line depicts those who received a low dose of psilocybin first, a trivial non-psychoactive dose. And they show about half of the effect that those who received the high dose showed. And I would argue that this is one of the first really clear demonstrations of the extra pharmacological effects of this intervention. So a lot goes into these sessions with preparation, guiding, and facilitation during the experience, and follow-up and aftercare. That all has substantial therapeutic value, and I believe this is a good depiction of that therapeutic value. It is not really just a drug in, healing out type of approach. This is really a psychotherapy approach, whereas the red line, I think, depicts the effect of the overall package, and the blue line depicts the extra pharmacological effects, everything but the drug. And as soon as we administer a high dose of psilocybin to those who received the low dose first, they come right down to where the high dose first folks were and stay there. So these effects were published in 2016. At about the same time, our colleagues at Imperial College London published a somewhat similar, strikingly large effect of psilocybin in treating patients with treatment-resistant depression. We see changes in the Beck Depression Index from pre-treatment to 1 week after treatment. Precipitous drop in most folks from a moderate to severe depression range into remission. But what we see in this treatment-resistant depression population is a number of folks begin to creep back up to pre-treatment levels of depression after about 3 months. This was in 2016. In 2020, we published the results of a waitlist control trial in patients with major depressive disorder, where we showed after treatment 1 week, 4 weeks, all the way up to 12 months after treatment, over 50% of the individuals who treated were in remission from depression after only 2 doses of psilocybin. And over 70% of the individuals in that study showed a clinically significant response, which was at least 50% reduction from baseline levels or greater. And these effects persisted out to 1 year post psilocybin. These were 24 individuals. It was still a small sample. On the left side, you see the averages. On the right side, you see the individual trajectories in what we like to call a spaghetti plot. You see each line, each individual's trajectory, and by interrogating this graph, a really important point to take away is that, yes, some individuals had a rapid reduction in depression that persisted. Other folks had a reduction in depression that then popped right back up to pre-treatment levels at about 3 months post-session. And then yet still there are at least 2 conspicuous individuals, the most conspicuous of which is the individual at the top of this graph who was the most severely depressed entering, and they seem to be a non-responder, as is the person with the dotted pink line going through the center of the graph. So what we can say here is that for some folks in this sample, there seemed to be a rapid and enduring therapeutic effect of psilocybin. For some folks, there was a less durable effect, and for some people, they were non-responders. Following that, last year, our colleagues in London published the results of a direct comparison of 2 doses of psilocybin to 6 weeks of escitalopram, showing what I would argue is at the very least non-inferiority of psilocybin to escitalopram at the 6 week post initiation time point. And this was on the quick inventory of depressive symptoms, which was their main pre-registered outcome. They showed no significant difference between psilocybin and escitalopram at 6 weeks. But on a number of secondary measures in this right-hand graph, the Hamilton Depression, the MADRS, the BDI, and also a number of other measurements such as well-being and flourishing, there was a modest to substantial favorable effect of psilocybin over escitalopram. And finally, a single dose of psilocybin was administered to over 230 individuals in a multinational phase 2B clinical trial sponsored by Compass Pathways that was just published in 2022 within the past month. And in this study, patients were randomized to one of three conditions: 1 milligram of psilocybin, which is a trivial non-psychoactive dose of psilocybin; a 10 milligram dose of psilocybin, which is a modest dose but not thought to be a therapeutic dose by many; and a 25 milligram dose of psilocybin, which is expected to be a therapeutic dose. And what we find is a rapid reduction in depression severity, which survived out to 12 weeks post-treatment in patients who received the highest dose of psilocybin, but no such effect in people in the other two dosing categories. This is a remarkable effect, and this to date is the largest and most rigorous drug administration study with treatment-resistant depressive patients. In this modified intent to treat population, they do show a modest effect of psilocybin, but what we need to follow up closely and really better understand were a number of adverse effects that were also reported in this population. So more information is coming out about that from what I understand, but essentially there are 5 individuals who had a serious adverse event related to suicidality, and those were all in the high dose psilocybin group. The details are a little unclear yet, whether these were severe or serious adverse effects, and there's a subtlety in language where one would relate to hospitalization and possibly a suicide attempt or something other medically seriously complicated, or whether there was just a substantial increase in suicidal ideation that was concerning. The sponsors really need to be a little more clear about that so people understand what those effects were. But those are not effects that we've observed in patients in more general trials of major depressive disorder writ large. So there we have mood disorders. Let me quickly work through reported effects in patients with substance use disorder. There were thousands of studies on psychedelic drugs that were published in the 50s and 60s. The vast majority of which do not really meet modern criteria for rigor and reproducibility in science. In 2012, Krebs and Johansson published the results of literature search and meta-analysis, where they identified a sum total of 6 studies in which they felt there were adequate controls in the study of LSD as a treatment for alcohol use disorder. And upon meta-analyzing these data, they found a favorable effect of LSD over the control conditions that were used in these studies, variously placebo or some other active drug condition or treatment as usual. And these all hang together and comport with Humphrey Osmond's claim that between 1954 and 1960, he treated over 2,000 patients, and he claimed an abstinence rate of 40 to 45% abstinence at 1 year post-treatment. But again, that hadn't been peer-reviewed or published. This is his clinical report. Much more recently, our colleague here, Matt Johnson, in the Department of Psychiatry, in 2014 published the first ever study of psilocybin to treat patients with tobacco use disorder in a 15-person open label pilot study. He basically showed that after treatment, folks who had been smoking a substantial amount were biologically verified abstinent smoking with exhaled carbon monoxide and urinary cotinine for not only 6 months follow-up, but this LT long-term is at least 1.5 years after follow-up. So in this study, over 80% of individuals who were treated with psilocybin remained abstinent for over 1 year of smoking, and that completely blows the standard of care. Maybe the gold standard treatment, varenicline or the patch, you would expect about 30 to 35% abstinence at 6 months. This is 80% abstinence and over a year later. Matt is now just about completed his randomized control trial following up on this report, And I don't want to spill the beans, but it seems like there's still an incredibly impressive effect directly comparing psilocybin to varenicline. Right about the same time, our colleague at NYU, Michael Bogenschutz, reported the effects of psilocybin administration embedded within a course of mind motivational enhancement therapy. And between the baseline, the first 4 weeks of treatment and motivational enhancement therapy, you see a decrease of drinking, both drinking days and heavy drinking days. And then between weeks 4 and 5 was the first psilocybin administration. Then we see a precipitous drop in drinking days and heavy drinking days that was sustained for at least 36 weeks. And Michael Bogenschutz just recently, within the past month, published the randomized control trial following up on this, where he compared psilocybin to a high dose of diphenhydramine under the same kind of therapeutic setting and setting conditions, and showed, again, a reduction in heavy drinking days and percent drinking days with psilocybin compared to diphenhydramine. With the last few minutes, I want to give you a hint about my thoughts in what may be explaining all of these therapeutic effects. Matt Johnson, Al Garcia-Romu here in the Department of Psychiatry conducted a study in which they asked people, if you have spontaneously stopped quitting after having a psychedelic experience, can you complete our study, tell us all sorts of things. One of the questions they asked was for people to reflect on various withdrawal symptoms and how severe and intense they were after their psilocybin-assisted quit success compared to previous quit attempts. And while people reported a lot of physiological effects like insomnia, fatigue, drowsiness, headaches, nausea, were no more or less severe on average compared to previous attempts, it was actually affective components of withdrawal that seemed to be substantially less severe after psilocybin compared to previous quit attempts. So this gave us a lot of room to begin to think about what could be going on here. In my first NIH-funded study, I demonstrated that in blue, 1 day before a psilocybin administration compared to teal 1 week and yellow 1 month after psilocybin administration, a substantial reduction in amygdala response to emotional stimuli. So we see a transient reduction in essentially negative affective processing, or neural correlates of negative affective processing, at a week that kind of recovers at about a month later. These are all in healthy individuals, and these individuals reported a similar reduction in self-reported negative affect, reduced a week and then bounced back up to baseline levels a month later, accompanied by an increase in positive self-reported positive affect over those time periods that sustained at least to the 1 month post-treatment time period. And I saw a similar reduction in amygdala reactivity in patients treated for depression. So in our waitlist control trial, we showed not only a reduction in amygdala reactivity to negative emotional stimuli a week after psilocybin treatment, but a correlation of that amygdala reduction with therapeutic effects at least out to 3 months post psilocybin. This is the beginning of my argument that negative affect may be a transdiagnostic process that is targeted by psilocybin and may be a core component not only of depression, but also of substance use disorders, especially to the degree that negative affect is a core component of craving withdrawal that leads to the development and maintenance of substance use disorders. We spoke a bit about mystical experiences when earlier in the talk. A remarkable effect of psychedelic drugs is that patients and healthy participants rate high-dose psychedelic experiences to be among the top 5 or single most meaningful and spiritually significant experiences of their lives. What we show in these graphs is that attribution is a function of the strength of mystical experience, MEQ30 being our mystical experience questionnaire. It may also be that strength of mystical experience predicts therapeutic effects. So these two graphs from our treatment of patients with a late-stage cancer diagnosis demonstrates a significant and somewhat substantial correlation, negative correlation between mystical experience and both depression and anxiety, such that stronger mystical experience predicts a greater reduction in depression and anxiety after treatment. We also see this effect in patients treated for tobacco use disorder. Al Garcia-Romu demonstrated a strong correlation between mystical experience and change in craving, confidence to abstain, and temptation to smoke after psilocybin experiences in our lab. In a larger survey sample, we demonstrate that acute mystical effects may actually predict psychological insights that people encounter during these experiences. It may be that not only having a mystical experience, but encountering personal psychological insights are really at the core of healing, at least for mood disorders. And these insights tend to lead to increases in psychological and cognitive flexibility after the experience. And in this path analysis, it was worked out that it's really this cascade of experiences, mystical experiences leading to personal insights, leading to increases in psychological flexibility that most strongly predict decreases in depression and anxiety, at least in a larger survey sample. And we have corroborating evidence for this in our study of patients in our waitlist control trial. We administered a test of cognitive flexibility before and then a week after treatment for depression. We saw not only an increase in cognitive flexibility, but also an increase in neural flexibility, defined as dynamic connectivity, or the variability of connectivity of the posterior cingulate and the anterior cingulate gyri, which are variously involved in self-referential processing, as well as cognitive conflict and conflict resolution, or cognitive flexibility. So we're really seeing on multiple levels, from behavior to self-report to neural measures, a change in variables that relate to cognitive and psychological flexibility that are also correlated with changes in depression severity from before to after treatment. So to summarize, there's potential efficacy of psychedelics in treating mood and substance use disorders. It may be that negative affect and cognitive control are potential transdiagnostic therapeutic targets, and it may also be that neuroplasticity may underlie these potential effects. And I see that Dr. Potash is coming on. I believe I may want to leave just a couple minutes for question and answer. Is that the case?
That is exactly the case.
Thank you. I just, before that, I want to acknowledge the remarkable multiple teams of individuals that I have had the privilege of working with within and outside of the institution, without which none of this work would have been possible.
Fantastic. Thank you, Fred. That was extremely interesting. Tell you what, I wonder if you could, of course, this is a very clinical audience. I wonder if you could say a few words about the likelihood of psilocybin becoming clinically available in the near to midterm. Any sense of what that looks like?
Yes, indeed. There's a lot to say about that, and a lot to speculate, really. There are 2 multinational clinical trials that have been approved by the FDA and the EMA. One with the sponsor Compass Pathways, who recently published the results of their phase 2b trial to use psilocybin to treat patients with treatment-resistant depression. We were one of the study sites for the USONA sponsored trial to treat major depressive disorder writ large. They've recently locked their database for their phase 2b trial, and they're beginning to analyze those data. The effects of psilocybin treatment in treatment-resistant depression to date have never been as impressive as the effects to treat major depressive disorder. Treatment-resistant depressive folks suffering from treatment-resistant depression are more likely to encounter lots of challenging life experiences, including suicidal ideation, attempts, and successes. And so there seems to be a higher incidence of those types of SAEs in the recently published TRD trial. We don't expect those to occur in the major depressive disorder trial, and we expect greater signal with major depressive disorder than TRD. If people are getting incredibly excited about TRD, despite the report that has just come out, I think we have a lot more hope that major depressive disorder may be a treatable indication and an improvable indication. And I think it may be possible that within 5 years, this is complete speculation, but within 5 years, we may see some signal of approvability of these compounds for treatment of mood disorders. That said, there are significant challenges to scaling and rolling out these interventions.
Mm-hmm, mm-hmm. Thanks, Fred. Tom Sedlak says, do you see particular advantages to psilocybin versus other psychedelics in terms of focusing future development?
Yes. Psilocybin itself has the benefit of not being spelled LSD. LSD having an awful lot more cultural baggage and reticence in a number of corners of the world. Psilocybin also doesn't have direct dopaminergic affinity. There are some kind of molecular and pharmacological reasons why we may expect psilocybin to be a a more kind of palatable and manageable compound than LSD. There are a number of other psychedelic drugs, including DMT, 5-MeO, DMT, 2CB, ibogaine, mescaline. There are, literally books and books full of research compounds that could fit within this pharmacological category. Nearly none of them have IND enabling studies. There's a long developmental pathway to getting them into clinical trials. That is a substantial kind of benefit of psilocybin, is that we can get it into clinical trials at this point. Large questions abound here. The psilocybin experience is 4 to 6 hours. Do we need people to be in a psychedelic state for all of that time for the therapeutic effects to occur? Or could we find a shorter acting psychedelic that yet has just as much efficacy, but a lot less burden logistically and a lot less time that we have to have people experiencing these subjective effects? There are a lot of interesting compounds that are in the development pipeline that could answer some of these questions. And another question is, do we need the psychedelic effect at all? I believe we do, but that is an empirical question. I would love to be proven wrong there.
Thanks, Fred. Nathan Hewitt says, thanks for the talk. In most of the studies you cited, were there placebo groups in which patients received similar follow-up to the treatment groups, therapy schedule, et cetera?
So, kind of, very few. So the escitalopram comparison, there was no true placebo condition in that study. Everybody received a psilocybin-like session with either psilocybin or placebo. Those who received psilocybin got 6 weeks of placebo pills. Those who received placebo during the experimental drug session received 6 weeks of escitalopram. So that is really a comparison of psilocybin to treatment as usual rather than a straight placebo. The cancer trial, the comparison condition was a trivial dose of psilocybin, which yet may theoretically and possibly have had some kind of therapeutic effect of its own. I am conducting a trial in patients with major depressive disorder and co-occurring alcohol use disorder, in which I am using a true placebo. But this has been a vexing question in the field, because the question is really, how do you blind a mystical experience? And what does it mean to give someone a straight placebo when the subjective effects of this drug are so strong and so well expected, so reliable? And for many people, giving them a placebo may turn that into a nocebo. As far as, there's a lot of functional unblinding with these drugs. About 2 hours after capsule administration, pretty much everyone in the room knows whether the person usually knows whether the person received active compound or not. So an approach in the alcohol use disorder randomized control trial was to administer diphenhydramine as an active control. There was no placebo condition in that study either, but using diphenhydramine to people who didn't have a really strong expectation or understanding of what to expect, they did seem to maintain the blind a bit better than others have. There are a number of other active control compounds that have been proposed with varying degrees of success, but I think none of them have really hit the mark yet.
Well, Fred, gosh, there are more questions, but we're out of time. And I'm thinking maybe the folks who have additional questions can email you. I'm sure you.
Yes, please. You can find me online or in my.jh.edu, or yeah.
Thank you. That was very, very interesting, very stimulating. And thanks everybody for tuning in. Have a good week.
Thank you all. Thank you, Jimmy.